Thank you everyone for taking out time today. We are here to conduct the first session of the knowledge series, Eldercare in the Time of Corona. I want to take this opportunity to thank all of you for being here. I know each one of you are doing a great job of managing the seniors, our seniors here through your various initiatives. I want to thank all of you for doing that. I think that makes India a very, very safe place. A special shout out to the frontline workers who are going above and beyond the call of duty to manage the current crisis. And I'm sure all of us lit those diyas last night as a show of solidarity to those frontline workers. So this little effort is to put out and knowledge share all that we have learned over the last 35 years as Genesis Healthcare, to be able to share what best practices would be in times of a pandemic like this, how our staff in the US is managing those 400 centers, keeping the morale up of the 70,000 employees while we are managing all the residents. Our effort has been to succinctly put together all those best practices and showcase them today. Of course, we can't put everything out because there is shortage of time, but we have tried. I want to take this opportunity to thank Nat Health for giving us this opportunity to set up the Nat Health Forum dedicated to senior care and rehab. It helps us to mainstream senior care in the healthcare system. I want to thank CII for being the conduit to the government of India. I want to thank the Association of Senior Living for being the visionary that they are of setting this up well before its time. And I think they are reaping the benefit of that for sure. I want to put out a special shout out for Ms. Preetha Reddy, the Vice Chairperson of Apollo Hospitals, Mr. Vineet Verma, the CEO of Brigade, Colonel Achar Sridharan, who is a visionary of his own kind from Kowai Care, Mr. Adarsh Narhari, who is the CEO of Mantri, and of course, Mr. Ankur Gupta, who is the CEO of Ashiana. A quick note on the admin items. We are going to mute everybody and put everybody off video for obvious reasons. All questions can be submitted through chat, and we will definitely take them up at the end of the session. Over to Sharmari, who is our Senior Director for Clinical and Nursing Operations in Genesis. Shar, all over to you.
Thank you very much, Nanki. I appreciate it. So as Nanki said, I am Sharmari Adkins. I'm the Senior Director of Clinical Operations for International. I've been a nurse for over 20 years. I've worked in infection control for half of that time, for 10 years, and got my certification in infection control about 5 years ago. So that's been beneficial for this particular pandemic. There are some special needs that elderly people have when we're thinking about situations such as this, and we're going to talk a little bit about that. Okay. So I think we're having a technical problem. Give it 1 second. Or a couple of seconds, maybe. Okay, I think we might be there. All right, so we will get started. As soon as there we go. All right, so one really important aspect of this outbreak is that it changes so very rapidly. If we think about it, really, we started hearing about this in January, even though I feel like every day we hear things, and so it's kind of overwhelming, but it's only been It's April. It's been, 90 days, 95 days. And think about the extent of how rapidly this has expanded. And we didn't know that much starting out about this particular coronavirus. Remember, they were calling it novel coronavirus, new, right? So we have to be flexible and we have to be agile and be willing to change things in order to ensure that we're using best practices as we learn more information. So I like this cartoon because, it's kind of like, oh, we won't do anything and maybe it'll just go away. We'll wish it away, right? And that's really not possible. And we have to remember that. Okay, so I know that we all know this, but I can't help it. I'm an educator at heart. So we have to talk about some of these symptoms of this particular illness. And, as at first particularly, it was compared to influenza. But we need to remember this is not influenza, and it is very contagious. The symptoms, as I think we all know, fever, coughing, sore throat, people that are short of breath. The problem with this particular virus is we're finding that other symptoms exist. So now we have had people that have nausea and vomiting and gastrointestinal symptoms, and we test them and they're positive. We have people that have had, especially the elderly, who don't always present like you or I would, because their immune system is not quite as good. It's a very frequent problem that the elderly will not run a temperature as someone younger. So you may not see that particular fever, but they may still have the illness. So that's always important for us to remember, and we're always looking for, we always have to be suspicious of, is this COVID? We had a patient, or there was a case, I don't think it was Genesis, but of somebody that had conjunctivitis, so pink eye, commonly called in the United States, and actually this person tested positive. So you can see how very difficult it is to kind of keep track of what's going on with the illness, because there are so many potential presentations as far as symptoms. So the takeaway here is any kind of symptom with any elderly person that's acting, a little off, our radar should go up during this pandemic. Is this person experiencing this particular illness? So again, I feel like we all know this, right? This is kind of old news, but the transmission is from droplets. Somebody that coughs, sneezes, maybe they spit when they talk, I don't know, and you inhale that, and that's how this disease is transmitted. And that's why they're asking for that social distancing. So we have to back off of one another, which is difficult. And that's one of the things that we're going to address a little bit, is that social isolation that can happen from having to be farther apart from others. One thing that's still evolving so far as information is this an airborne illness? And so we need to understand the difference between droplets and airborne. So droplets are basically, it's a heavier particle. So anytime that somebody has a illness that's droplet related, such as influenza, that droplet goes as far as it's being propelled, and then it falls. Okay. Now something that's airborne goes up into the air. So I actually got some powder, and I was kind of like, if you spray that up in the air and you can see those little particles going, and they hang in the air for just a little while before they fall down, that's airborne. Okay, so that's the difference between those two ideas. So you can see why an illness like tuberculosis, which is airborne, is so contagious. I don't even have to be in the room in order to make someone sick. Now, they don't think that COVID is airborne. The times that we have to be concerned about COVID becoming airborne is with aerosolization. So think about an aerosol spray, like hairspray, or if you have aerosol deodorant or cleaner, and those particles kind of shoot out and go, further into the air, in the atmosphere. That's aerosolization. Now, one thing that happens with aerosolization is droplets fall onto surfaces. What we have recognized is that with this particular illness, with COVID, that aerosolization can happen when we're doing some healthcare associated tasks. If you have a patient that has to be suctioned, if you have a patient that needs a breathing treatment, such as a nebulizer treatment, those particles can go into the air. And so that makes for some specific safety issues, which we must address for healthcare worker safety and then for other resident safety. So I think everyone knows that we have issued the social distancing, and that's, I have symptoms, I don't have symptoms, everybody has to keep away from one another, right? Again, that can make for social isolation. All right, so now we're going to talk about some basics. How are we going to stop this? How do we stop the spread? And, a lot of the answers are pretty simple on the surface. Very simple, right? Hand hygiene. That's something that people hear all the time. They kind of discount it. But are your staff in an elder care facility, are they performing hand hygiene? And if they are they doing it right? Because that's an important aspect of this. How many times have I seen somebody that's doing hand hygiene and it's this, and I'm done? That is not appropriate hand hygiene. So we have to make sure that people understand how to correctly use soap and water. Now, you can also use an alcohol-based hand rub, such as this, okay? It should be 70% alcohol. Can people see me? I really, okay. So we have to use something like that. Products vary, so you have to kind of use whatever the product says. It does have to be at least 70% alcohol, okay? The important thing with something like this is that you get all the surfaces of your hand. You just can't do this. You have to go to the thumbs, you have to go to the top, and you rub until it's dry. Now, we probably all know this. No, I'm still rubbing, okay? We probably all know this. However, the problem is that a lot of staff don't know it, okay? A lot of less educated members of our staff may not know how long they have to do this, or that if I'm using soap and water, I need to do hand hygiene for 20 seconds. Happy birthday to you, happy birthday to you, twice. Rubbing the entire time, bubbles, soap, okay? Then dry your hands. That's appropriate hand hygiene. It's important that we are looking at our processes to see that people are doing those things, okay? Somebody has to be in charge of that. We have to have a system. Then we have cough etiquette. The best thing for cough etiquette is a tissue and then throw it in the garbage, okay? So, and then throw it in the garbage and then hand hygiene, okay? If that's not possible because you don't have a tissue around, then we do the little I always think of it as Dracula, my old cape. So those things are important. They're simple, but who's watching that? Who is monitoring that to ensure it's happening? Of course, staying home if you're sick. And this is a struggle because particularly in the United States right now, we have pollen everywhere. It's spring and flowers are blooming and the trees are blooming and we have a lot of pollen and we have a lot of people with allergies. So do I have symptoms of COVID or do I have an allergy, and how do we break that apart? Okay. So some of what we do is out of an abundance of caution. I'm sure we've all heard that, okay? And then we can't underestimate the importance of cleaning, particularly high touch surfaces. So that we have an image there of a doorknob. This hygiene has to happen on a frequent and regular basis in order to kill off this virus, because you can pick it up from a surface, then you touch your face, and now you have it, okay? So it's very important that housekeeping plays a huge role in infection control, okay? All right, so this is a particular problem for our population in long-term care, okay? We have people who are very, very elderly usually. These are people that are at risk for this illness. We have people that have chronic diseases, and chronic diseases put you at risk. So that's something that we have to really look at. Also, healthcare workers are at special risk, and we think about this, and we have to be very, very cognizant and very aware of that, because if you have a healthcare worker that picks up this illness, I always think of it as acting as a little bee going from flower to flower to flower, and they're just spreading, they're pollinating this illness, okay? It's very important that we protect healthcare workers, not only for their sake, but also for the sake of the people for whom we care, okay? So Genesis has done some specific things. You know, everyone has to look at their own center, their own facility, and adapt things to what works for them. Even within Genesis, we do this. When we operationalize things, we're like, well, we know that in this area, this may work. In this area of the country, up north, the northern people are different from the southern people. I'm southern. But so we have to account for and make adjustments to those practices while still maintaining our standards, okay? So we have, and you can kind of think of it as like, you know, if you're playing a sport such as soccer, you know, you have the rule book, so everybody has to follow the basic rules, and then we have the playbook, which is, you know, what individual people are doing, okay? So in an individual center, but you still have to follow the rules, but we may adjust them a little bit, right? Okay, so we have rules for visitation within the center, and those rules are for everyone. If George Hager, our CEO, comes into a facility, he has to follow the same rules as anybody else, okay? And that's very important that we make sure that we're maintaining those practices for everyone, okay? So we have to screen everyone. Everyone that walks in our door, and what we're doing is we've channeled people into one door. So if a facility has multiple entrances, we've locked entrances, we've put up signs that say, you know, you have to come to the front entrance, so that we can make sure we don't miss anyone, that we are checking everyone. Another important aspect of screening people is empowerment of the people that are doing the screening. You know, we can't necessarily use a physician or nurse. They're needed in other locations. And so we've trained people to be a screener. But so a lot of times it's a secretary or receptionist that we've trained to, you know, ask these questions, and they're asked in a systematic fashion. There's a form that they're filling out. But these people have to be empowered to either ask the question of a clinical staff member to know, hey, I need to push this up to a physician or a nurse, and so let me ask about this, or to say, you know, I'm sorry, you can't visit right now. And they have to have the authority and the power to do that. We have, as leaders, we have to invest that in them, okay? Management of staff, this is difficult. This is a very difficult time. The front line healthcare workers, they're right there in the midst of it. It's stressful. It's stressful for me, and I'm just taking phone calls. And so I can't imagine being in a center and having to deal and cope with everything that's going on, and the fear and the anxiety. So it's very important that we put things into place to help our staff. And we're going to talk a little bit about that. Keep them motivated, keep them supported. You know, our residents are terrible risk of isolation right now, social isolation. We don't have any visitors coming into our centers. And so it's very important that staff engage with those residents, and that we have alternative ways of letting the residents communicate with family members and with loved ones. And so we're going to talk a little bit about that too. Okay. And then we have some infection control measures that we're also going to talk about that are pretty basic. Okay. So one thing that we've done as when we're thinking about our employees is we engaged with risk manager partners. So if you have a risk management partner that you work with on a daily basis, that they can be helpful to you in thinking about employee health situations, kind of working through some of the potential risks involved with this type of pandemic. And our, you know, our best practices, we're wanting to make sure that our employees are healthy, that they can come to work, because if they're not there, we don't have anyone to care for our residents, and ultimately to keep our residents safe. Okay. So again, think of that bee going from flower to flower to flower, and if they're sick, they're moving that illness along. Okay. So we want to keep our employees' health, but we also want to manage risk for the company. Okay, for operations. So some of the things that we can encourage staff to do is to take a break from the news. It's overwhelming. You can't escape. It's on social media. You turn on the television, it's there. You turn on the radio, and sometimes you just feel like, where can I go to escape this news? And so sometimes it's turn off the radio, turn off. We're not saying to avoid things and bury your head in the sand, but sometimes you just need a break. Okay. Because it's exhausting. You have to take care of your body too. You still want to be healthy. You still want to try to, even though, you know, you may be stuck at home, maybe you can make sure that you're eating well, that you're, you know, going to bed and getting adequate sleep, that you're exercising. All those things can help with that stress of dealing with this. And of course, we have to do this while maintaining our social distance, right? We also want to connect with others. And so thankfully in our world today, that's much easier to do. I mean, look at what we're doing right now with this connection across the world, right? I've seen a lot of things that I just think are just so unique and wonderful. We had, my husband showed me this virtual choir. So it's like 50 people that have gotten together and they're singing together, but they're not in the same room. They're doing it through video. And those kinds of things can help people feel engaged and help people feel connected to others. FaceTime. I'm having to do that with my granddaughter. We're getting on FaceTime and talking. And that's not easy, but I don't want anyone to get sick. And so that's where we are right now. Okay. But we want to make that connection with other people. Especially important for the elderly who are at risk for isolation anyway. So this is true in a center as well as out in the community. So we need to make a special effort to assist them with this technology that maybe they don't know that much about. And so that's part of what GHC is doing, is using some technology. We can take a break by listening to something funny. I have a tendency to go that route. Or listening to some music. Deep breathing, that can help. Just let's all just take a deep breath and you let it out, and that decreases your heart rate. That's actually physiological. Okay. You take a nice deep breath and let it out, your heart rate goes down. So you do that a couple of times and that's helpful. Okay. There are all kinds of apps for meditation and relaxation, and those can be helpful as well. Okay, so we also want to make sure we're showing appreciation for the people that are out there taking care of our loved ones and out there taking care of people. So these are some of the things that are happening in the US is people are putting out signs in front of centers. I saw a video of staff that were kind of dancing in the hallway. We're feeding staff, that we got a picture of pizza there. So we're providing like lunch or dinner. We just want them to know that we recognize that this is a very difficult time. And so, we're trying to support our staff. Some other things that HR is doing is allowing people to cash in some vacation time. So if I have, a week of vacation and I can't take it right now anyway, and I need the money right now more than I need my vacation, then I can cash that in. So, and of course that has to be, dealt with on an operational level. Are we able to do that? But that's a benefit for our employees. Another thing that that's happening is that vacation is rolled over. So if I were going to lose vacation time, because we do that in the US, if you don't use it, you lose it. Genesis right now is rolling that over because we know that you may not be able to use that vacation. Where am I going to go, right? So, they're rolling that over for people so that you don't lose that vacation. Okay, so that's another way we're trying to support our staff. So because visitation is very restricted, just healthcare personnel, only essential healthcare personnel. So we even have, here in the US, we use hospice, and hospice will come into a long-term care facility for somebody that's at end of life. And we've even limited that. So we're doing that in a different way. We're kind of using some virtual visitation. We'll talk a little bit about telehealth. But an important part of this is you have to communicate with people. So my mother-in-law is actually in a center here in the US, a Genesis center, and they call us and they say, this is what's happening. We can get on Zoom with her. We can, try to connect with her through technology. The only way that visitation is allowed right now is very minimum, and it's for end of life and compassionate care only. And even then, the person cannot have any symptoms. They still have to be screened. Okay, it's tough. It's tough, and you can imagine if you have a family member that's very ill at end of life, and how difficult that is, because many people want to be with their loved one and are not able to at this time. So some alternatives to visitation. As I said about my mother-in-law, you can use Zoom, WhatsApp, FaceTime, Google Duo, window visits. We have people that are coming up and there's like a little designated window. You can see the picture there. Maybe bring a grandchild by, pet by, whatever is important, but just where we're still staying safe. And one thing you have to remember, of course, is clean that down after that resident is left, right? Because that's an important component of this, is are we being safe? So this can help with some of that sense of isolation. And as I said, I think we're lucky and fortunate that this is occurring in this day and age where we have the ability to have that technology. Okay, so I know I've said this, but we're screening everyone, and we've allocated one door for entry. And if anyone says they have any symptoms, we're like, you're going to have to go, and we're going to have to do something else. If that's a staff member, we're going to have to figure that out. That's tough, because it's not like we just staff with extra people in order to make sure that everyone that comes to the building, if we have to turn somebody away. So staffing contingency plans, emergency plans must be made before you hit a peak of this, so that you can say, okay, I'm not going to let people leave until I know that I have the number of staff that I need. So if I'm working day shifts, I'm going to hang on a little bit. Are all those evening shift people okay? Are they all able to work? And I know that I have to stay over if we don't have people to care for our residents. And so that's one of the discussions that Genesis is having with staff is, what are you going to do if you have to stay? Do you have childcare? Have you made plans and arrangements for that? what if you are taking care of a family member? Is there some other way that that can happen if you're a staff member, so that, you know, those people are prepared for the fact that they may be there in the center working longer than they originally planned. One thing that we're doing now, which we weren't doing at first, is we are having everyone in patient care areas, in a building, in any facility, is wearing a mask and eye protection, okay? And it doesn't matter if the center has a case of COVID or not, mask and eye protection in patient care areas. If we have a center that has a case of COVID, then those centers are wearing mask and eye protection everywhere. So you could be in the business office and you're wearing a mask and eye protection, okay? All right, anyone positive, we have to turn away. And as I said, I know that this makes staffing difficult, but we cannot allow sick employees to work. And think about the ramifications of allowing someone who is sick with this illness to work. And then you are going to have a domino, a ripple effect, right? And you're not going to have any staff. You know, so this one staff member, is it really worth letting one sick staff member come in and then have that ripple effect occur? So even though it's tough, you know, we have to make sure that we're not allowing people who are sick to work. And we have to come up with alternate plannings. Okay, so employees with acute respiratory infection, if I have symptoms, I'm just supposed to call. Don't come to the center so that you can be turned away. Just call and say, hey, I'm having an issue, right? If somebody is positive, one challenge that we're having is that different states have different timelines for how quickly testing is occurring. So, you know, along with the CDC and APIC, and these are all infection control gurus, the World Health Organization, you know, they've developed some plans for how do we say that somebody is able to come back to work. So one of the things is you can't have run a temperature for 72 hours. And during that 72 hours, you can't have used medication to lower that temperature. It has to be without medication, that you have no temperature, okay? We want to make sure that any symptoms that somebody had that caused them to leave work are resolved before they come back. So for a confirmed or suspected case of COVID, they have to be screened by the physician. And we're using two strategies for return to work. And again, with our risk manager partners, we developed those guidelines. So we have a test-based way of allowing people to come back to work, or we have a non-test-based, because again, those tests, you know, it can be 8 hours and you have a result, or it could be 14 days. And it just varies widely depending on the lab, depending on how overworked they are, how many tests we're doing. We've done 1.7 million tests in the United States. So you can see where, you know, they're pretty under the gun too with getting these tests back quickly. So for that test-based strategy, there are certain criteria that have to be met. Resolution of that temperature, no medications, right? I don't have respiratory symptoms anymore. And a negative COVID test. This is the difficult part, right? We're having trouble getting these tests back very quickly. And so this test-based strategy is not used as much as the non-test-based strategy, okay? And with the non-test-based strategy, 72 hours have passed and no fever, so same criteria. Improvement in respiratory symptoms, same criteria, but 7 days have passed since those first symptoms. So if I'm sick today, I believe it's the 5th, I can't seem to remember days right now, then I have to wait till the 12th, okay? And so you have to track that as well. Who's tracking that for your facility? Who's making sure that people have stayed out the correct number of days? Who's in contact with that employee to make sure that, you know, how are they doing? What's going on with you? we have to stay supportive of people, even if they're not on our premises, okay? So we have to think about that and make a plan for that before we ever have COVID in the building, okay? All right. Once somebody does come back, they're masking. They're masking for return to work. We're doing that right now anyway for everyone in patient care areas. So that's not anything different. All right. So who is being tested, and when is a case a little scary? What is this prolonged contact? So prolonged contact is approximately 15 minutes within that 6-foot radius, okay? And look at that word, unprotected, so no mask, okay? No goggles, no nothing, and I was with this person, so maybe it's a spouse, maybe it's a family member, okay? So we're excluding these people for 72 hours. So if we know my husband has COVID, he's positive, the nurse calls you, my husband just tested positive, okay, well, you have to not come to work for 72 hours, okay, because you have prolonged close contact with that individual. So that's one way we're trying to prevent transmission, is by, excluding people. Now, that 15 minutes, I want everybody to remember, that's guideline, okay? So if somebody says, well, I think it was maybe, I was with that patient for maybe 10 minutes. Well, okay. We're going to have to use our professional judgment there and go, yeah, I think that we're still going to exclude you, right? Because we want to err on the side of caution. Once it's in the building, it spreads like wildfire, okay? So transmission, prevention of this is critical to saving lives. There's no treatment. There's only supportive care for this illness. That's one thing that's different from influenza. Influenza, we can use something like Tamiflu, and we can help with symptoms. There isn't anything like that for this illness right now because it's new, right? So the best way to deal with this and to manage this is to keep it out of the facility. So how are we going to do that? Well, we're going to do that screening, right? We also need to implement some infection control measures, okay? And let's talk a little bit about that and how do we do that? We're tracking cases. So as a company, Genesis is tracking cases. And we also want to make sure that we're providing education to all the various staff members, okay? So that they understand what to do. So, what we're doing is we're assessing residents for signs and symptoms every 8 hours. So we're doing, we developed a little assessment. We're doing vital signs, okay? We're getting all the vital signs. There was a moment when people were like, well, I'm just going to get a temperature. Well, no, as I said earlier, presentation can vary, and especially for the elderly. They don't always run a temperature. Makes it very difficult sometimes. We want to get an oxygen saturation level if that's possible, because if there's a 3% drop, that may be what you see for that individual that's experiencing this illness, for that resident, okay? We want to maintain consistent staffing as much as possible. So we want to make sure that if I'm taking care of, Nanki's mother, okay, for example, that I'm the caregiver every day and we're not changing things up, because there's the possibility of, particularly with our staff, of them encountering somebody as they come and go from work. And so we want to keep consistent staffing. Again, it's that B, right? Going from flower to flower to flower. We can minimize that with consistent staffing. Now, there are more reasons than infection control having consistent staffing. We could cover that a different day. We also want to enhance cleaning and disinfection of high-touch surfaces. There's a difference between cleaning and disinfection, okay? So I want you to think of a dirty plate after you've eaten it, a dirty utensil after you've eaten. If it still has some of your potato on the fork, you can't just kind of spray something on it and say it's disinfected. You have to clean it first, get that gunk off there, get that potato off there. Now we can do some disinfection, okay? So you have to think of those as two different steps, okay? It's important. And we have to do high touch surfaces. So if something is visibly on the surface, it has to be cleaned, then disinfected, okay? And that's how you kill these viruses. We need to make sure that we're communicating with other healthcare providers. Are we telling emergency transport and hospitals that are taking a patient, hey, this person has got these signs and symptoms and we're concerned about COVID, okay? It's very important because we're just going to be spreading it all over the place if we're not communicating with one another, putting a mask on that patient as they travel, having the emergency folks wearing masks. And centers that are positive are not taking new admissions right now. We take our own people back. So if somebody went out to the hospital and then they are better and they're well and they're able to come back, we're taking those people back, okay? We're trying to dedicate an area of the building for those new admissions. So only one unit or one ward or one floor where the new admissions are coming back. And that way we can try to kind of keep people that have been out in the community that are maybe more likely to have encountered something, keep them in one section and keep our other people over here in this section and try to minimize that transmission between those folks. And that's where that consistent staffing comes into play too, okay? If a center is dealing with COVID, there are no new admissions. And we take that from the last day that somebody actually had a case, and we'll walk out 14 days from that. Okay, this is when we can talk about us starting to take admissions again. And that's just to make sure that we don't expose people to somebody in our building that's already there, okay? So monitoring residents, it has to be systematic. You cannot just be like, well, I told the nurses and they're supposed to be getting those vital signs and making sure nobody's got a new cough, a new headache, a new whatever the symptom is. It has to be systematic, okay? So some of what Genesis has done, and which is very helpful, is using IT. So we developed a little assessment. It's every 8 hours. Those nurses are being prompted, hey, you've got to do this assessment and get those vital signs and look at those signs and symptoms. And that helps with that being very systematic. We also are going to be looking at, if we have a change in condition, communication between the nurse and the physician, what are we doing so far as diagnostic tests, viral panels? So you got to look for influenza. You also have to look for COVID, and they're not mutually exclusive. It's not like, okay, well, I have flu, so I don't have to worry about COVID. You could have both. So it's important that we're looking at it from that perspective, okay? That we're making sure that we're kind of covering all our little bases and that we're not missing something to ensure the safety of folks, okay? So we talked about consistent assignments. That's talking about within different floors, within different units. So one of the centers that I work with has 3 floors. If you're a worker on the 2nd floor, you're not going to the 3rd floor, not for anything, okay? So they're trying to avoid each other as much as possible and keep people kind of, confined to their one little location so we don't have people transmitting things. We have to limit transfers out of the building. The family should not be transporting people. Right now that's just not a good idea because they're out in the community and there's the possibility that they could give something to a resident and then that comes back to the building. We do have people that get hemodialysis and they have to go. That's an essential service. They're not going to live without it. So for those folks, we have them wear a mask when they go out. They do hand hygiene when they go out. When they come back, they're still wearing a mask and eye protection, and they are having a mental breakdown here, having to change their clothing when they come back. So somebody that's been out for dialysis, mask, hand hygiene, eye protection. Let me change my clothes when I come back to the center because we're trying to eliminate that whole idea of, people that are out in the community that are more at risk coming back with something and spreading it amongst the center. All right, so personal protective equipment. You know, this is pretty a hot topic in the United States. I don't know kind of what the situation is in India and availability of some of these items. We have masks. So you have this standard mask that a lot of people are familiar with. It's a surgical mask. These are loose fitting. You can kind of see on the side, these don't seal, okay? So these are good in certain situations, but this is not the optimal thing if you're dealing with a patient who is a confirmed COVID, okay? Then you have this. This is an N95 mask, and an N95 mask is often used in the United States for construction and for, I mean, we use it in healthcare, but it's also used in construction. People that are painting, that kind of thing, to keep them from inhaling, so that dust, some of those fumes. Gowns and aprons to keep clothing protected. Gloves, of course. Gloves are an always. I don't even think about that as extra, right? and then there are these face masks. This is covering, this face shield is covering his whole face. This is the best picture I could get. And then there are these goggles, okay? It's important that people understand how to use these. These are not without their own kind of educational needs. People have to understand the way that that to put things on, to take them off, so that they don't cause transmission inadvertently. Okay, so we're gonna talk about that, show a little video about that. There are some common sense things, right? So when you're thinking about transmission of infection, you know, clinical staff members are taught to think about some basic things. You can't just say, well, in this situation, do this. You know, if you're going to go in with a patient that has, you know, some particular problem, just do this. And then if they have this problem, just do this. It changes based on what's going on with that patient. Okay. So some questions that clinicians are taught to ask themselves. Might I encounter body fluids? You know, urine, stool, you know, mucous membranes, eyes, nose, coughing, gloves, right? Does the person have a respiratory illness, which is what we're talking about right now? I need a mask, right? I might need a gown. Aerosolization of particles, like we talked about, you know, them getting floating into the air. Okay, well, I probably need that face shield and some eye protection, because those particles might get into my eye, into my mucous membrane. So those are all important things to think about, and they're pretty common sense. One thing that we have to think about right now, because personal protective equipment is kind of like gold, okay? We have to protect it, but we also have to make it available. So what is your facility doing to secure, to securely store your protective, personal protective equipment, while still making sure that it's available to, like, those night shift nurses? And how are you tracking the use of personal protective equipment? How are you making sure that you're going to have enough? That's an important aspect. So we've done some reuse and extended use of PPE as we're starting to run short, okay? And so the little paper bag there is an example of the reuse of a mask. So basically what we're doing is we're having staff to use a mask, take it off in a very specific way, and then put it in the bag. And that allows for reuse of that mask, so that we can extend how long our personal protective equipment is available. All right, so we have a little video about how to reuse your face mask, okay? We're running a little short on time, as things have taken a little long, so I think I'm gonna skip this and this respirator. I believe that this is going to be available for you, so you can kind of look at this, or we can send you links for these. I will tell you that this is a very important aspect, so we'll make sure to get those links to you so that you can watch videos about you know, making sure that masks are being used appropriately, okay, and extending the use of that PPE. All right. So universal masking is in use in Genesis for everyone. So everyone, if you work in the business office, you're still using a mask and eye protection unless your office door is closed, okay? We're keeping patients in their rooms. We're not doing group activities right now. We're individualizing room activities. We have rehabilitation is not happening in our gyms right now. And we're making sure that we dedicate equipment if we have a patient that's positive. So we're not moving a blood pressure cuff from one patient to another. What are your physicians and nurses doing with their stethoscopes? You know, are they disinfecting? These are things that we have to think about and look at, okay? So that we have a plan and that everyone understands what's necessary to keep people safe. Because we have no group activities or meals going on, this is very difficult for residents' psyche, for their psychosocial health. So one of the things that a lot of the centers are doing is they're setting up a patient, like we've got this young man here, he's in a wheelchair, he's got the tray table, and they're having people sit in their doorway. So we still have the separation, but they're still kind of together. So they're kind of out in the hallway a little bit. They can talk to one another. They can still see other people, but we're still keeping that social isolation that's necessary, okay? So to prevent transmission, once you have a case, if you have a case, we want to move people to a private room. We're going to move the roommate. If we have a semi-private room with 2 people, we're going to move that roommate to a new room. Sometimes that's not possible. Sometimes our whole facility is full, and so we can't do that. So what do we do then? Well, we're going to treat that roommate as if they are positive. We're going to pull a curtain or put up a divider so that we can have a barrier between those 2 patients. We're going to have the patient that is positive have a bedside commode, a potty chair, so that they don't have to get up to use the toilet and potentially spread that illness, okay? So those are all important aspects of care that we want to think about. How do we prevent transmission? But you do have to treat that roommate as if they're positive, because there's a good chance they are, okay? We got to think about high-touch surfaces and disinfect them, you know, very carefully. Remember, cleaning is different from disinfection, so we got to do both these things. And this requires housekeeping, and this requires maybe a change to some of what they normally do. If you have housekeepers that are just during the daytime, maybe from 7 A to 7 P or something, and they are only there for a short amount of time, can we extend that time so that they can do more cleaning and disinfecting? They want to wipe down areas. It's very important, and you want to think about all these different high-touch areas, you know, rails, desks, toilets, sinks, doorknobs, handles, light switches, elevator buttons. More bacteria on an elevator button than there is on a toilet seat, okay? So those have to be disinfected. We're talking about the mail and transmission potentially occurring through packages, because there's some porous surfaces, sometimes on cardboard and envelopes. So how do we take care of that? Well, we're holding the mail for 24 hours, because 24 hours seems to be the extent to which that virus will live on a surface. So we're holding the mail, and once that 24 hours has elapsed, we're distributing it to the residents and staff. You have to think about this as an operational thing too. Who's doing this? How are we making sure that 24 hours has elapsed? That's something that needs to be thought about at a center level, and administrators need to think about. So preventing transmission, another important aspect is if a patient discharges. If you have someone goes to the hospital or they go home, what are we doing with that room? So remember that we think that this is a droplet situation, okay, those heavy droplets. However, if somebody has been in that room and they have COVID and they've had a breathing treatment or suctioning or anything like that, out of abundance of caution, we're closing the door when the patient discharges, we're waiting 2 hours, and then we're cleaning and disinfecting that room so that if there are particles in the air, there's enough time for air exchanges to occur and for everything to kind of settle. And then we can clean all those surfaces, okay? All right, so memory care is tough, right? We have patients, we have, 55 to 65% of a long-term care population has some type of dementia. It's very difficult with dementia and memory care units. What are we doing for these individuals. They forget. You have to stay in your room, Mrs. Smith, stay in your room. 3 minutes later, she's back out in the hall because she's forgotten. She cannot retain that information. So how are we managing these people? So some of what we're doing is one-on-one person-centered engagement plan. So we're going and we're spending time with these folks. We're doing individualized dining experience like we talked about with the people in the hallway. We're getting people up and walking them because a lot of these residents are very mobile, and you can imagine all of us now having to be in our house so much. It's nice just to go for a walk, right? And to get up and moving, and that's very important. So we want to make sure that we individualize engagement. One of the things that I heard was giving a patient a cloth, and so the staff member is kind of cleaning, and the resident is doing it too, because a lot of these folks were wives and homemakers before, and so that's just kind of a natural thing. You hand them a cloth, they start cleaning. Okay, now is it good cleaning? No, but they're doing something, and it's an activity, right? So you want to think about the particular resident, what their abilities are, where they are in the stage of dementia, because the activities are going to vary greatly depending on that individual, and develop a plan for these folks. We're using telehealth. So with telehealth, you can get a psychologist, maybe a wound care specialist, a physician, and that way we have less people coming into the building. A lot of our facilities are using physicians and nurses along with an iPad, an iPhone, and the physician can direct the nurse, hey, what are you seeing here, there, what's going on with this person, and that helps us to have less people in the facility. Nutritional counseling can happen this way with a dietitian. Okay, hospice is happening this way. This is to keep people out of our facility, but still keeping residents with the services that they need. Okay, communication is very important. We have some structured talking points because it's uncomfortable sometimes for people to talk about something that's going badly, right? And this is not able to be helped, but it is certainly difficult to manage and deal with, right? So this the structured talking points, it gives people a consistent message, and it provides updates to families and gives the folks that are talking to families some guidelines and some ideas about how to approach this conversation. It gives confidence to the staff as they are talking, right? And it gives confidence to families as they're hearing from people. Silence is very difficult. If you're not hearing from anyone, your mind runs rampant and your imagination can run away with you, right? So it's much better to contact families and to set up that information ahead of time so that they understand what's going on. They're having group calls. So they were setting up some Zoom calls where it's just a scheduled Zoom. The family can hop on. The administrator, the director of nursing can talk with the family then and let them know this is what's happening in the facility, since we don't have visitation right now. Communication is very important, not just with families, also with the staff. If you're not communicating with your staff, you may not have staff, right? Because they get scared and they're like, this does not work this. And that communication, it needs to be frequent, and it needs to be honest, and it needs to be sincere and transparent. People should know that what you're saying is the best information that you have, that you care about them as an employee, as a family, as a resident, and you're doing the best you can in this very strange and different situation that we're in. Social services can be of great benefit in these situations. So if you have somebody that's a social worker or maybe just a really good communicator, this can be of great benefit for residents, for families, to help reassure them they have special ability and they are taught to communicate very well with people and to give reassurance. Communication should be systematic, and one of the things that Genesis does, because we're a big company, and so you may think about this if you have multiple centers, is systematic communication with a trickle down kind of philosophy. So we're going to communicate to the leadership, who are going to communicate to center-based employees, the leadership and those employees. So we got corporate, then the center leadership, and then that information is trickling down to staff that are on front lines. And that's critical. And, you know, corporate employees are looking at what's happening in the world, what's happening in my neighborhood, what's happening nationally, locally. Every day I get on, every morning I get on the computer right now, I look at my state and what's happening in my state, and where are we with the outbreak, because that's going to be important information for me. Okay. This also helps with processes and guidelines. You know, as things are changing, because it's changing very rapidly, that information needs to be given to staff so that they understand, you know, what needs to be done now. What's the new evidence for how we prevent transmission of this illness? And so that's something that is done in Genesis through some weekly calls. We have a whole web page kind of set up that you can click on, get different information. It takes you to the CDC. It's getting that information so that you have the best processes that you can in place to prevent illness, okay? And give support to frontline staff. A lot of us get on a phone call and just talk with centers and say, okay, you know, how can we help? You know, we're here to help you. How can we do that? It's important that we track a case, okay? This is kind of bread and butter in infection control. We're going to identify who is that first primary case, who did they come in contact with, so that I can try to protect those people, notify them, hey, you know, you were exposed to this person. And then we develop an epidemiology curve, which allows us to see kind of, you know, what trajectory is this illness taking? Is it getting, are we still getting more illness, or is that dropping down now? Education. Can't overstate the importance of education in this situation. You got to make sure staff understand how to complete hand hygiene. Is it happening right? What are the symptoms of the illness? Even though we all know the symptoms of the illness at this point, and we feel like everybody knows, you got to make sure, and you got to make sure that they understand that with the elderly, this is of particular importance. Okay, how's the disease transmitted? You got to make sure people understand. Sanitation procedures. You know, you can't just take your tissue and ball it up and throw it on the desk, is actually what I did when I said I have a tissue, because that can cause spread of illness, right? You know, reporting the occurrence of symptoms of patients and staff members so that we can track those folks, okay? So all those things are very important as we educate our staff to make sure that, you know, they understand how to prevent transmission. All right, so I feel like I've talked enough, and so I'm gonna throw it over to Caroline now.
Thank you, Shar. I appreciate that, and I think you touched on a lot of really good points, and I'm going to hopefully take it from here and fill in a little bit of that information that I'm sure everyone wants to know, of how to keep our residents engaged, how to keep them happy, how to keep them fulfilled with life, how to help mitigate the isolation that we're requiring and that we're putting upon them based on our efforts to try to stop the spread within our facilities. As many of you may know, recreation plays a huge part in keeping our communities vibrant, keeping our elders engaged, keeping our seniors fulfilled and having purpose for the day, and helping to prevent depression, helping to prevent further exacerbation of medical conditions. Depression has been very much a disease that can exacerbate comorbidities and lead to further declines in overall health. So we really want to do our best to keep our residents engaged in this isolating times, and making sure that we're still meeting our needs while we are preventing the further spread in our communities. So recreation staff can do this a few ways, and we really need to pull on the leverage of technology in our centers to do this. We can do this a few ways: providing social visits to the facilities and to each resident through the phone or through a video call. We can do what we like to call armchair travel, where you can sit with them and do some perusing of the internet on different websites, different videos, different things to stimulate them, stimulate their imagination. Maybe they've always wanted to go and visit a place. So there's different websites that you can pull up and use via video conference, where you could be, the recreation staff could be in their office, and they could have an iPad in their room, and you could do some web sharing of the screen and things like that, similar to what we're doing today. So we could still keep our safe distance as well as engage them in some individual activities. We could do a book discussion or trivia, or even do a PowerPoint of some different videos or some images or a topic of interest to them over the phone as well. So using our imagination is really the key for us at this point. We can send inspiring messages if residents have cell phones or family members or emails, and they're using those types of technology. We can send them daily inspiring messages, things to keep their spirits uplifted. We can facilitate letter writing and sending mail that they could eventually open. So it's something that keeps them having something to look forward to and keeping them engaged and in touch with people and the outside world as well. Again, as Shar mentioned earlier, we can help the residents stay connected with family through the video calls, and recreation can help to schedule those calls, bringing in an iPad and providing that to the resident and setting up that Zoom video call, and also bringing in supplies to the resident to help them write any letters to their family. Maybe their grandkids, they haven't been able to see their grandkids or their family in a very long time. They could write letters and stay connected that way. Additional online engagement. Again, this could be done in a one-to-one side-by-side room activity with the resident using a laptop or an iPad, or it could also be done remotely, similar to the platform that we're using here, where we can go on and search many different kinds of websites that are interactive. Here are a few that we utilize in our facilities. There are websites, the ones that I have pictured here are one where NASA actually does a live webcast where they can actually see real-time videos of outer space if that's of a personal interest to that resident, or they can peruse through many photo galleries on the web page. The one at the bottom is the Pier 39 Sea Lion. It's a live camera that's set up in California at some of the sea lion areas where they could just watch wildlife. There's several of those that could be found on the internet. It's just a matter of searching and being creative and seeing what's out there that's available. And I'm sure in India, you all might have some great ones as well. For in-room activities, again, where recreation staff could go into the room, they can bring in music, they can go and do a sing-along with the resident in their room. Maybe they choose to go in and create a short story, or maybe sketch or draw things together. They could bring in newspapers or other media for the person to be able to engage in and look through. Anything that they're bringing into the room, they should consider leaving it there, and it's something that the resident could then engage with at a later time on their own independently. Or if they're bringing some supplies in, making sure that the supplies are things that could be wiped down and disinfected if they're going, and bringing them back to the recreation department, or maybe going to another resident's room and utilizing those supplies. So just keeping those things in mind. So it will limit the types of things. We won't be able to be as creative with some of the crafts and things that are of porous materials just to help prevent that spread and transmission. But I think that we're still having some good engagement with some of these more simple activities. There's web pages. Here's an example of some free printable art that you could print off from the computer, print off a paper, print off a drawing, and bring it in and have the resident paint it, or have the resident color it in with colored pencils, or paint or markers, things like that. So there's lots out there. It's a matter of searching and being creative and coming up with a list of resources for your team. Social, spiritual practices, many of those things can no longer be done in gatherings, in group services. So there are a lot of platforms that are putting those types of things in an online sermon or prayer platform. Online videos, as I mentioned before, there are a lot of travel videos, music concerts, YouTube. You could search different places around the world where people have posted videos, where you could sit and watch a few videos or provide that information to a resident to be able to look up on their own for an independent activity. Games and other tabletop activities we can also bring into the room. Again, if it's a deck of cards, we might consider leaving that in the room for the residents for them to be able to use at another time and disinfect later. We can also provide sensory stimulation activities. This would be things that are aromatherapy that we can bring in to the room. Again, if we're going to be bringing in those types of things, it would be recommended to for this to be brought in for a resident that is not COVID positive, because that is a respiratory illness. We don't want to be introducing any smells or scents that could be provoking or cause them to cough or cause them to have an increase in their shortness of breath or symptoms. So this would be for our healthy residents. We can bring in various different scents and sounds, sound machines, maybe bring in some instruments that you as the recreation staff play and they listen to, audiobooks, podcasts, things like that. Put things outside the windows. If they have a room that's near a window, put out some bird feeders or some things that can visually stimulate them as they spend many, many hours in their room unengaged when staff are in there, or obviously when family members are not on video calls. So put some things outside, maybe they're wind chimes or their windmills, or there's things of visual interest that they can look out and look at in their environment to keep them engaged and stimulated. Next, I would like to move on and talk about rehabilitation. That is actually my specialty area. I'm a physical therapist, so this is something that is near and dear to my heart. And in this time of social isolation, it does make it more challenging to provide rehabilitation to all of our residents that are in need, because we need to limit that treatment in the gym area. We must be creative and bring our treatments to the bedside. We can do that by bringing what we call bedside kits, where we can bring equipment, we can bring it on a cart, bring it in the room, equipment that can be easily disinfected, that can be utilized with the residents and then brought out of the room. We quite often will rely on the environment, what we can do with them for ADLs, and get creative with that. And a lot of what our therapy goals should be based on function. So it allows us time to be in their living space and work on things like moving around and dressing and bathing and grooming and meal preparation and things like that. We ask that the patients wash their hands before and after the treatment. This helps to prep them for their own hand hygiene before using our equipment and our tools, and then after we get done with them, just to help keep them safe. Again, during our sessions, we take another opportunity to help provide respiratory hygiene and cough etiquette education to help further remind them in this time to prevent any spread of germs. We as the therapists carry our supplies. We carry some alcohol wipes. We would be masking and doing the same types of infection control processes as the nursing and physician staff in the facility. Would be wearing a mask and face and goggles or a face shield. And we want to prioritize our scheduling. We want to look at all of the residents that we must see in the day that are requiring therapy for the day. We advocate scheduling the long-term care residents in the morning, the residents that have been there at the facility, so we can treat those residents, lower their risk of contracting anything from us as a therapist coming into their space, and any new residents coming into the facility. If there's a short-term care wing, or there is a new resident coming in from another facility or the hospital, we would want to schedule that person towards the end of the day, because if that person is asymptomatic and could possibly be a carrier of the coronavirus, we wouldn't want to treat that person early in the day, and as Shar said, be that bee that is going and visiting all those other residents through the day, and now we've put our long-term care residents at risk. So we want to prioritize how we schedule our patients. One common tool that we utilize as therapists is a gait belt, and in almost all instances of interactions where we're getting patients up and moving them, we want to be using a gait belt for their safety. However, gait belts are typically made of a canvas and are a little more challenging to abide by the disinfecting rules for in between patient use. So it's best practice if we just assign one gait belt to the patient and leave it in their room, particularly if they are a coronavirus positive patient. We would leave that in their room until they no longer require rehabilitation services, or if they discharge out of the facility, then we would move forward with disinfecting of that gait belt. But while we use that gait belt, we can do some barrier protection. So we could wrap it with a plastic bag over the front portion of the gait belt, where it'd be more susceptible to having germs and any of that droplet and aerosolization of respiratory virus, where it would drop towards the front of their body. We can wrap that with plastic to help keep it safe, and then we can spray it with disinfectant and leave it to dry overnight. That would be once we're done using the gait belt with that patient for that period of time. And again, as I mentioned, we would be creative in our approaches to what we provide for in-room treatments. Things like bringing in the equipment to exercise, to still do strengthening activities with them, using their environment, having them perform reaching activities into the overhead cupboards, using daily things such as a calendar, or maybe their medications, and work on executive level management activities with them as far as memory and processing and cognitive performance activities, anything that we can do that doesn't require us to leave their room. So we typically get very creative and still try to achieve the therapy goals that we have set forth for that patient. And lastly, just to sum everything up, is, as Shar mentioned, every day we're learning new things about this virus and this disease. So it's really important that as an organization, and you set your plans forward, be flexible as things change every day. You may need to change that guidance. You may need to update your resources or your plans or your information that is getting out to the frontline staff. Know that that is okay, and we're making the best decisions that we can today with the information that we have today. So understand that this will be a fluid plan, and you may be making changes very rapidly. In some case, from morning to evening, the plans may change. So. Well, thank you all for your attention. I'm going to pass it back now to Neil and to Kate for some of our questions.
Great. Caroline, Shaw, great job. Really appreciate it. I think it was some great information and very helpful for a lot of people. So we're going to turn this over to some Q&A. We've received a few questions. Kate, I'm going to have you read the questions and then pose them to Shar or Caroline, whoever would be best to answer them. Before we do that, I do, again, just want to thank everybody for attending this call. We're going to extend the call a little bit to try to get through some of the questions. So feel free to stay on, or if you do drop off, we'll be posting the questions and some of the answers on the website as well, so we can kind of keep up to date with it. And as Nancy had mentioned, we're working on a series over the next few weeks. Please keep an eye out for some upcoming webinars to help you in all managing your centers. And again, I want to really send out a very sincere thanks and to you and more importantly the frontline healthcare workers. It's just such a challenging job out there. It's just so scary for everybody coming to work every day. It's just so important to embrace them and really show appreciation for what they're doing. And honestly, I mean, here in the United States, really risking their lives to take care of our patients and, our most valuable and valued members of society. So I think, again, we have to always keep that in the forefront of our minds. So Kate, if you want to go ahead and pose some of those questions. Thank you.
Sure. The first question I had, Shar, you'd probably be able to answer. Can you please include a brief on how many staff members actually reside within each facility and whether any staff member comes in daily from outside?
So make sure I understand the question correctly. If there are people that live in the facility, so
Correct.
So in the United States, that's not really a practice that we do here, where people will live in, caregivers live in the facility. So we have a lot of back and forth. People are working 8 hours. A lot of people, nursing staff, work 12-hour shifts. So, we have a little bit of overlap when caregivers come and go. However, if you don't have that, if you do have staff members that stay 24 hours a day, it's actually a benefit from an infection control standpoint, because they're not going out into the community with the potential to pick up the illness and then come back. But we're going to have to, screen those people if they do come and go, and ensure that if they do go out into the community that they have not picked up anything, and continue to screen them. I think I would probably put into place screening of those folks at least once a day to ensure that they haven't been exposed to something during that time frame.
Great, thank you. One question is, are there any fruits and vegetables that one buys from the market? Are they free of the virus?
So recommendations are that you clean any fruits, vegetables, raw products that you would be consuming, just with some water and scrub a little bit. Anything that's being cooked, the heat is going to kill the virus. So far as raw fruits and vegetables, though, just cleaning those. Sometimes some people will use a little bit of vinegar, like 15 mils of vinegar into some water, and that can help to clean. If there's packaging, you may want to wipe that down depending on like how the product is delivered to you. Okay.
Thank you, Shar. That answered another one of the questions, was what are the safety measures when we receive such food parcels? Do you have any more details on that piece?
Well, this virus is pretty susceptible to lots of different types of cleaners and disinfectants. It's not a very hardy virus when it comes to that. It can be eliminated very quickly with alcohol, with a bleach product. In the United States, the FDA, the Food and Drug Administration, has a whole list of disinfectant products that can be utilized on this particular virus. But simple things like alcohol and bleach will also kill the virus. So even wiping down a packet of alcohol wipe. Okay.
Thank you. So, talking about the sanitizer, will adding additional isopropyl solution to sanitizer help?
Well, I mean, you know, desperate times call for desperate measures. So I'm not going to tell you not to do that, because if you don't have, if you have a product that's at a lower level of alcohol, so if you have a hand sanitizer and it's at 50% instead of 70, I'm not going to tell you that that you shouldn't do that. But I will tell you that the addition of alcohol can dry out the skin. And so drying out the skin is a potential problem for a couple of reasons. One is that people might quit doing hand hygiene because it hurts, it stings, right? And most of these products have emollients in them to kind of, you know, give you some moisture while you're cleaning off your hands. Breaks in the skin can lead to other types of infection. We can't act like this is the only thing in the world, right? There are other things that can happen to us. So we have to be mindful of that as well. However, as I said, you know, we're doing things here in the U.S. I've talked with some of the infection control leaders here in our company, and we're doing things that we would have never done before. So I certainly would not say, yeah, don't do that. I mean, 70% alcohol is the recommendation. Something is better than nothing. Soap and water for that adequate amount of time is going to be, you know, very beneficial.
Great. Another question is, are there specific immunity boosters to vulnerable elders during these days?
I'm afraid that's a question that's probably I'm not going to be able to answer, but we can probably seek out an answer and, you know, get back with that particular question.
Great. Are there any specific first aid procedures developed for COVID that include precautions and emergency?
So that is an excellent question, and it is one of the very difficult things about this. And I've read some things where emergency room physicians, you know, they're trying to put on their PPE. They really need to get to a patient very quickly. It makes it very difficult. You know, the best thing is to make sure that if we can, that we have those face shields and goggles and, you know, any personal protective equipment readily available so that staff can very quickly put it on. You know, we have to protect our staff, just like if you think about in a situation where there was a car accident or if there was an electrical line down, we're going to make sure that we're safe in whatever first aid we're providing. So we're going to, you know, try to move the patient. If it's a electrical line, turn off that electrical line, because it doesn't do anybody any good if we now have two patients because, you know, we ran in without thought during an emergency. Okay.
Thank you. In today's lockdown situation, do you pay full salaries to staff who are unable to come, or have you been asked to stay away from attending?
I'm going to throw that over to like
Yeah.
Dean.
So we are paying our staff. We have a process on how to pay the staff. They would use up their sick and benefit time. We provide them with all sick and benefit time. So they would use up their sick and benefit time first. Then we work with our workers' compensation company, and we are paying them full salaries. So yes, we are keeping our staff whole, for lack of a better word, through this process. You know, again, talking about valuing our employees and making sure that we're supporting them. We are doing that. It's obviously a very difficult situation for our company financially to go through this, but we are making sure that our staff are being kept whole.
Great, thank you. Any suggestion on how we can manage with limited availability of PPE? And this has been covered a little bit throughout the presentation, but if you wanted to elaborate on that.
So we are, again, doing things that we wouldn't normally do. We're extending use of gowns, and we are reusing masks that we would normally dispose of as soon as they were used. So essentially what's happening is staff members are coming into the facility, they're having their screening. right there at the door. They've got their mask and their eye protection. They put those on, and they use those masks and that eye protection all day. And so long as the mask does not get wet, they're putting that mask into a paper bag. The videos that we kind of ran out of time to watch kind of demonstrate how to reuse that mask. And if you have somebody that's, say, works in dietary, and maybe that mask does not get moist over the course of the day, doesn't get wet, and it is still in relatively good shape. I actually have an N95 mask here. So so long as, you know, the straps haven't gotten too stretched out and the little metal strip is still going to fit along your nose bridge well, they can reuse this. And like I said, there's a specific way that we're doing that. So if you get on and watch that video, that can kind of help. And then we're extending use with gowns. So we're making sure that, you know, if we're wearing a gown that, you know, we're using it for a longer time than we would have in the past. Okay, and then with the goggles, of course, those are, you know, you keep those. And basically at the end of the day, these can be wiped down with alcohol and reused by another staff member. Okay.
You know, one other suggestion that we've heard quite a bit with protecting PPE and protecting the masks too. So Shar showed those goggles. There are full face shields that go down. And if we're actually sending out to all of our centers, so all of our centers have the full face shields. If you're wearing the full face shields, it helps prevent any sort of virus or any droplets getting onto the N95 mask. So it's actually almost like a double layer of protection of having the shield as well as having the mask on. So it's preventing that mask from getting dirty as well. So, you know, a strong suggestion, something that we've implemented in our buildings, is the full face shields.
Great, thank you. I have one more question here. And this one, maybe Caroline, you might be able to answer, provide some more detail. Any suggestions on how to prioritize care activities in case of limited staff availability or the worst case scenario?
Okay, sure. And I would also ask for Shar to chime in as well from a nursing's perspective. I can give sort of a perspective from a rehab standpoint. For those residents that are lower level functioning and may require a lot more physical assistance, that would require up close and personal, where we wouldn't necessarily be able to provide rehab, keeping that social distance. Most of what we do for rehab professionals is in someone's space. So again, I would prioritize those more involved residents for earlier in the morning, where the staff, when they've come in for the day, have had a decreased exposure, having even traveled around the building, having them schedule, and if they could schedule their residents in clusters. So if there's different wings or floors within the facility, having the staff, maybe the rehab staff are assigned one staff person, or, you know, they're assigned to a specific floor or a specific wing. So then that reduces their moving around in the facility and their possible transmission of going from one end of the facility to another, and then therefore decreasing the risk of bringing something into the resident's room. So those would be my two strategies from a rehab standpoint, and that same strategy could be applied for recreation services as well, when they're trying to go and stimulate and provide individual one-on-one. If it's a new resident to the center or to the location, maybe the recreation services only provide remote video chat or a phone call, one-to-one facilitated interaction, and they don't actually do a bedside in-room session with them. Shar?
Yeah, I agree with all that, and you know, consistent staffing, as Caroline was mentioning, and trying to keep the nursing staff, nursing assistants, caring for the same residents. You know, a couple of things that normally in the U.S. we give showers at least twice a week. So as part of activities of daily living, the residents are having that care provided for them or with assistance, and we're not necessarily doing that right now. And do you really have to have a shower as often as that? So, we're kind of having to rethink some of what we would normally do in conjunction with a lot of the rehab personnel. They're assisting us with some of those activities of daily living, because that's something that occupational therapists and physical therapists help with anyway. So certainly they're able to help to provide some of that care. I think that the United States has also put out a plan for a rapid teaching and education of nursing assistants, so that they can very quickly, like I think it's an 8-day program where usually it'd be like 22, 25 days, so that they can quickly get people educated and at least providing some very basic care to residents. It's tough though.
One of the other things that I wanted to mention too, and Shar, you mentioned something that made me think of it, is the rehab staff. Because we are an integrated part within the facility, we are doing our very best to help step up and support nursing when it comes to, as Shar said, with ADLs, but also with providing an additional person to help them do their vital checks when they're monitoring their residents and they're checking on their patients. Rehabilitation therapists are trained to be able to take all vital signs and to be able to make all of those recordings. So in a lot of cases, if rehab has additional team members, they're going in and providing that to take some of that stress and strain, because it is such a frequency that they're having to check all the vital signs. So rehab is really stepping up and trying to help them in any way, which may be out of our normal scope of practice that we would do. But they're, given the circumstances in the US, they have relaxed a lot of the scope of practice guidelines for many of our professions in the healthcare industry because of the shortages in staffing. So that's one of the ways that we've been able to kind of help team together and overcome that.
Great. Thank you, Caroline and Shar. We have just one more question, and it has been talked about before, but maybe Shar can provide a little bit more detail. How would you rate a reusable cloth mask? And what would you suggest to keep the virus away, especially when we reuse these masks?
Okay, so obviously cloth mask is not the optimal thing. That's not the optimal way to go. But again, desperate times call for desperate measures. And so the problem with the cloth mask is that they tend to get wet, okay, and they tend to carry bacteria. Anything that's moist and and stays moist tends to hold on to bacteria and virus more. However, again, if we're having to go that route because there aren't any other options, obviously you would want to make sure that's laundered. So used for, until maybe it gets wet or moist, and then put it into the linen so that it can be laundered. There are guidelines related to gowns and cloth gowns, and they can have 75 washes, and then they're supposed to be, taken out of circulation. The important thing is that they get laundered and that they get cleaned on, at least a daily basis. Again, if you're out in the community and wearing a cloth mask, that's not as big a problem because you're not wearing it for, straight 8 to 12 hours working with individuals. So usually, 30 minutes, you got this mask on, and then you're done with it. The cleaning of it is important. It will reduce particles by, I think I read, like 30 to 40%. So it's better than not having anything at all. Okay. We are trying very hard not to go that route. We are trying very hard to conserve surgical masks and N95 masks by reuse and extending use, so that we don't have to go the cloth mask route. But again, in a really desperate situation, it will reduce particles. Like I said, I think it was 30 or 40% reduction. Okay.
Great. Thank you, Shar. This now concludes our question and answer piece, and I will turn it over to Nanki.
Okay, I was trying to unmute myself. So this is great. Thank you so much, Shar and Caroline. This is awesome. What we are going to do is there are a lot of questions that have come in regarding mental health, and we will delve further on the rehab side as well, Caroline, next week. We will come out with the dates and the time rather, pretty much it's going to be the same thing. But yes, thank you very much for your participation, everybody, and we'll see you soon.
Thank you, everybody.
Thank you.
Be healthy.
Thank you.
Stay safe.